Enalapril is chapter 44 on page 473 of your Lenny's textbook. So your enalapril is your ACE inhibitors. It's going to help with your hypertension. It's going to help with your heart failure. These are what they're indicated for. So if you want to understand your ACE inhibitors, your angiotensin converting enzymes is what it's blocking. It's inhibiting this. So if you're inhibiting this, you're hitting that renin, that whole system is getting blocked. So you're going to have less renin in your system, and it's going to basically allow you to excrete the sodium, which is going to lower your blood pressure in return. Okay, so what are the things of the baseline that the nurse is going to want to obtain initially before you even start any of this medication? All right, what are you going to obtain? There's two things. So the two things are going to be, you want to get your blood pressure, obviously, because you want to know where you started, and so you can know if the medication is even working in the first place, and you're also going to want to get your white blood cell count differential. That's very important because I think that this medication has something to do with causing issues, but I think it's more associated with Enalapril, to be honest, because that's what the textbook said. But still, to know that white blood cell count, you want to monitor that because that could be a side effect of ACE inhibitors in general. All right, so also this medication may take several weeks to get your max benefit, or it will take several weeks to get your max benefit. It's oral, it's a continuous medication, it works over time. Okay, so this white blood cell count is very important, and it actually has details in the PowerPoint about it, that you need to get this white blood cell differential count every 2 weeks for the first 3 months, and then periodically after that. So every 2 weeks for the first 3 months. That's kind of a lot, but it's like basically every 2 weeks for the first 3 months. So that's, yeah, every 2 weeks for the first 3 months of white blood cell count differential. All right, so for enalapril, your route is usually oral. Actually, enalapril is the only one that could be administered as an IV, according to the textbook, because it's all kind of talks about it as a chunk, as 473 is where it starts. You want to begin with the lowest dosage possible, because your first dose hypotension is at high risk, and increase the effect as you go, because this first dose hypotension is a big a bit adverse effect. You are allowed to administer with food. Okay. So you totally administer this with food, which is great. Monitor for that the decrease of blood pressure, because that's where is your target supposed to be. So your target for enalapril is going to be that 140/90. Okay, so your 140/90 is your target heart rate. Okay, so your heart, and if your indication was for heart failure, you want to look for lessening of signs and symptoms, your dyspnea, your cyanosis, your jugular vein distension, and edema. Okay, so blood pressure or heart failure, whatever you're looking for, but if it's used for indicated for blood pressure, you're looking for that target heart rate 140/90. Now, I'm pretty sure regular blood pressure is usually 120/80. So we're actually not trying to go like crazy. It's not like crazy. So this is for patients who probably had other routes. All right, so what are those high risk patients? I need to set this down. Our high risk patients are second and third trimester, class D. It's fetal harm. Okay, so our high risk patients are those pregnant patients. So pregnant patients specifically in the second and third trimester. It's in the PowerPoint, it's in the textbook. I see it all the time, second and third trimester. But it can also be a risk during the first trimester. It's just saying that this is like known thing. I'm gonna put on the light again. Okay. So other things are, so this is a class D. Infants who have been exposed should be monitored for your hypertension, your oliguria, and your hyperkalemia, because those are just side effects in general of the drug itself, which we know. All right, so other high risk, so your pregnant patients, and also your bilateral renal artery stenosis or history of oedema, which because those is a side effect, and renal arterial stenosis, anything with renal failure is contraindicated because you're going to be excreting all that sodium, which means you're retaining all that potassium, and that's really dangerous. If you're already retaining potassium because of this ACE inhibitor and you're excreting, you're at risk for tachycardia and all this. It's a big problem if you're retaining more potassium than normal. All right, so the caution, you're going to want to caution for salt depletion, because if you have salt depletion already and volume low, then your potassium is going to be even higher than, which is already an adverse effect, hyperkalemia. Your renal impairment patients, you're retaining that potassium, retaining electrolytes, which could be a problem because you're already going to be retaining it just because of the medication itself. Collagen vascular disease is another one, and potassium supplements, potassium sparing salt, substitution, your lithium. So lithium acts like salt a little bit. So sometimes when you have low salt levels, your body's going to retain that lithium. So if you have lithium at the same time as this medication, it's going to get to toxic levels. So that's very dangerous. All right, so some adverse effects to watch for is a cough, hyperkalemia. Your cough is going to be dry and irritated. If it bothers the patient, they can go and get it prescribed and look for a new hypertensive alternative. Hyperkalemia, obviously your potassium is going to can go drastically high. You're going to want to look for tachycardias or other problems that are associated with that. Fetal injury, we learned about the second and third trimester. It can cause harm. Your renal failure patients, and your neutropenia, which is why you look for a WBC count and differential every 2 weeks for the first 3 months, and then periodically after that. So the next thing we want to look for is that first dose hypotension, which is a common thing. And how are we going to minimize that as a nurse? What are we going to try to do to lower the risk of having this first dose hypotension? We're going to want to minimize by withdrawing a week before. Let me say that one more time. A week before those diuretics, before you start administering this, because you can add them on later, but this first dose, we're going to have to withdraw for a week, so it's less dangerous. The low initial dose, you want to start with a very low initial dose and then increase as you go up, which we talked about. This is how you administer. You want to monitor blood pressure for the first 2 hours and instruct the patient to lie down. If they start to feel lightheaded, tell them to lie down, because they can be a risk of fall risks and if hypertension even starts to develop. Now, let's say the patient does develop hypertension. They may need a normal saline infusion to increase those the pressure back to normal. Okay, so then the only thing you need to think about is drug interactions, but it really is the same as thinking about your adverse effects because they kind of go hand in hand. Our diuretics, because diuretics are going to be an additive effect of this low blood pressure, but also it's going to increase your potassium possibly. Your other hypertensives, it's just an additive effect. The drugs that increase your potassium can be very dangerous. Also, this high potassium levels that are caused by this drug is going to cause a decreased effect of your digoxin, because digoxin, if you have more potassium, it means it's going to have a decreased therapeutic effect. Lithium, because of the sodium being depleted, it's going to retain, because it acts as sodium. If sodium is low, it tends to retain that lithium because it's kind of like acting like it. And then your NSAIDs tend to decrease in effect. So if you have NSAIDs, they decrease in effect. Yeah. Other than that, that's everything that I know for enalapril that seems super, super important. Yep. All right, adios. I think I'm taking a break for the night.